All right, here we go, wonderful students. This is the chapter on fluid and electrolytes and acid-base balances. We won't go into acid-base balances in block 1 or parenteral replacement of fluids and electrolytes in block 1, as you're going to start getting that in block 2. Here are the learning objectives for this chapter. Please take a moment to review each one of these. Our body fluids perform several vital functions. These include maintaining blood volume, regulating our body temperature, transporting materials to and from our cells, and assisting with food digestion. And it also helps us excrete waste, and it lubricates our joints and tissues. Let's review the makeup of fluid in our body. We have approximately 40 liters of fluid in our body. The majority of this fluid, or approximately 2/3 of this fluid, is within our cells, or called intracellular fluid, or ICF. This is vital for cell functioning. It is comprised of things like oxygen, electrolytes, glucose, things like that. The remaining fluid, or approximately 1/3 of the fluid, is extracellular fluid, or ECF fluid. This is comprised of interstitial fluid and transcellular fluid, along with our intravascular plasma. This fluid is critical as it carries nutrients to the cells as well as carries waste away from the cell. Our body is comprised of about 50 to 60% of fluid. Men have more body fluid than women because they have more muscle tissue than women do. Women also have a higher percentage of body fat than men. Obese people have a lower percentage of body fluid because adipose tissue does not contain water. Older adults also have a lower percentage of body fluid because of muscle mass. Please go to your book to review the variations, or just to look over how, based on age and gender, the body percentages within the body, so you have a good understanding of how that decreases. Body fluids are considered solvents. Solid substances in our body are called solutes, a solute. Electrolytes are considered a solute. Non-electrolytes, like glucose, are also solutes, but they do not conduct electricity. Electrolytes also are charged. Positively charged electrolytes are called cations, and negatively charged are called anions. Our body is always striving to achieve a balance between these two, right? Between the positive and the negative, right? And we call that homeostasis. We get our fluids from various sources. Most of our fluid is gained through the ingestion of liquids, right? From us consuming liquids. Fluid is also contained in the foods we eat. Also, there is something called metabolic oxidation, which is a chemical process that literally breaks down carbohydrates and also provides fluids to the body. Intake varies depending on the person and circumstances. The average range is about 1,500 to approximately 3,500 milliliters per day. And the average is about 2,500 or about 2,600 milliliters per day. This slide reviews the intake and output averages and fluid balance. We lose fluid through our urine, our feces, through perspiration. We also lose what's called insensible losses, and that's when we breathe, right? So through our lungs, we lose about 300 cc's or 300 mils of fluid loss just by breathing, right? So this is an important slide. Pause. It's good to know. So pause the video and read through the average numbers on how we lose fluid, right? Because you need to know that. Many organs are involved in fluid and electrolyte processing and balancing. The primary long-term regulator of water and electrolyte excretion from the plasma is our kidneys, right? We know that. The cardiovascular system reacts to hypovolemia and a hormone called BNP that is released in the heart in response to an increase in blood volume and stretching of the arterial walls. This promotes sodium wasting and acts like a diuretic. It also inhibits the thirst mechanism, which leads to less fluid intake, right? The lungs help regulate acid-base balances. The adrenal gland controls our aldosterone. When aldosterone is released, it promotes reabsorption of sodium and water and excretes potassium as well as hydrogen ions. Our thyroid hormone influences fluid volume by increasing cardiac output and thus increasing the flow of blood through the kidneys and an increase in urine output. There are some key hormones that also help with this regulation. One of them is ADH, or antidiuretic hormone. When our blood osmolarity, or the concentration of the solutes versus the solvent, when that increases in our bloodstream, it triggers the osmoreceptors in our hypothalamus that stimulates our pituitary gland to release ADH. The ADH hormone increases the permeability of the distal tubules in our kidneys and thus allows for more reabsorption of water in the kidney and back into our bloodstream, thus decreasing the concentration of osmolarity of our blood and also decreasing our urine output, right? So you can see how it changes, it stimulates this process, and therefore the result being the decreased urine output. Of course, the opposite will occur when we have a lower osmolarity of the blood. The ADH hormone is suppressed from being released, and we have less reabsorption of water in the kidneys, and therefore we have an increase in urine production, and our serum osmolarity returns to normal. Our thyroid hormone influences fluid volume by increasing cardiac output and thus increasing the blood flow through the kidneys and an increase in urine output. The GI system absorbs water and nutrients as the food passes through. Alterations in the system can lead to dehydration. So you can see how all of these organs work together to stick with homeostasis, right? So it's critically important that we understand how the body's organs regulate fluid and acid-base balances, right? It's important, right? As a nurse, so that we can help educate our patients if a patient's lacking in one of those areas. In these next two slides, we will review how electrolytes and fluids move across our permeable membranes. This will include the process of diffusion, osmosis, filtration, and active transport. You do need to know the difference between them, okay? Because you've already had this information in your prerequisite classes like A&P, we're not going to go into great detail, but again, it's more of a refresher for you. If you don't remember it, though, please go back and study it because it's important that you understand what's happening in the body. Remember that in the body, water is the solvent, and solutes include electrolytes, oxygen, carbon dioxide, let's see what else, glucose, protein, amino acids. Osmosis is the process of the solvent or water molecules moving across the membrane from the less concentrated area to one of a more concentrated area in an attempt to equalize out that concentration. An example of this is when a runner loses water through perspiration and there is an increase in the solute concentration in the plasma because of water loss. The higher concentration solute pulls water from cells as well as interstitial spaces into the vascular compartment in an attempt, again, to equalize out those concentrations, right? Diffusion is the movement of molecules from an area of higher concentration to an area of lower concentration. The solutes are trying to balance themselves out among the solvent. When we have an increase in temperature, there is an increase in the rate of motion in the molecules and therefore an increase in diffusion. Schematic filtration occurs when the capillaries and the interstitial space move fluid back and forth. On the arterial side, when the hydrostatic pressure exceeds the constant osmotic pressure on the inside of the capillaries, there is an exchange of fluid that goes from inside the capillaries out into the interstitial space, resulting in edema. So you can see how edema occurs, right? On the venous side, when the hydrostatic pressure is less than the constant osmotic pressure on the inside of the capillaries, there is an exchange of fluid that goes from the interstitial space into the capillaries. In active transport, sodium and potassium move across the semi-permeable membranes with the energy from active transport. Okay, so you need energy for that. The sodium and potassium move to areas of lesser concentration, to areas of increased concentration of those elements. So let me repeat that. The sodium and potassium move areas of lesser concentration to areas of increased concentration of those elements. This slide shows how these move from intracellular spaces to extracellular spaces. This process helps maintain the concentration levels of higher sodium in the ECF and higher concentration of potassium in the ICF. So again, you need active transport when you're going to have molecules or electrolytes moving against a concentration gradient, right? It's not simply going to occur because of diffusion. You actually need energy to do that. Okay, so ATP, when ATP happens. If you do not remember ATP from anatomy and physiology, please go back and review the process, okay? Not to the point where you can memorize it, but so that you understand it, right? Because it really will help with understanding how fluid and electrolytes move and, you know, how they balance within the cells so that we can, and the tissues, so that we can maintain homeostasis, okay? It's important. Okay. Capillary filtration results from the force of the blood pushing against the walls of the capillaries. This pushing force is referred to as hydrostatic pressure. When the pressure inside the capillary exceeds the surrounding interstitial space, fluids and solutes are pressed out. The opposite occurs when the pressure outside exceeds the inside and the fluid moves back into the capillaries. Reabsorption is a regulatory system that helps prevent too much fluid and solutes from leaving the capillaries, regardless of the hydrostatic pressure. Colloid osmotic pressure produced by plasma proteins produces the action of pulling of the fluid back into those capillaries. Again, we're not going to go into acid-base balances, but you're going to cover that next block. It'll all make sense, though, if you spend the time here in block 1 really understanding the fluid piece, okay? How fluid is moved in and out of the cells, in and out of the interstitial space, in and out of the vasculature space, and third spacing as well, okay? Now we come to fluid imbalances. Hypovolemia, or fluid volume deficit, is the loss of both water and solutes in the same proportion from the ECF space. Both osmotic and hydrostatic pressure changes for the interstitial fluid into the intravascular space in an effort, again, to compensate for loss of volume in the vasculature compartment. As the interstitial fluid is being depleted, cellular fluid is then drawn into the interstitial space, leaving cells without sufficient fluid to operate, correctly. Young children and older adults are especially vulnerable for hypovolemia. Third space fluid shifting refers to the movement of body fluids from the intravascular compartment into the transcellular compartment in the pleural area or the peritoneal or the pericardial, joints, bowels, interstitial spaces, right? Once these fluids have shifted, it is hard to try to return them back to the ECF. This shift can be the result of a disruption in the colloid osmotic pressure mechanism. It could be fluid volume excess. Maybe it's due to hyponatremia, or a shift from intracellular fluid to extracellular fluid from trauma, for example. It could be for many, many things, right? Fluid volume excess or hypervolemia is a result of excessive retention of water and sodium in the ECF. This can be due to a number of things like kidney problems, heart failure. The water and sodium is depleted from the cells and pulled into the ECF. Accumulation of fluid in the interstitial spaces is known as edema. And it's important that you understand and be able to grade the level of edema, and the scale is on this chart here. And we have talked about this in class as well. Okay, so make sure again that you're able to grade 1 plus pitting edema, 2 plus pitting edema, 3 plus pitting edema, 4 plus pitting edema, and then what we discussed in class about brawny edema, right? With the taut, shiny legs, right? No pitting. Okay. The major electrolytes and their functions are listed on this slide. You need to please pause this video, take a moment to make flashcards so that you can get this information into your permanent long-term memory, right? It's really important that we understand how sodium, potassium, magnesium, calcium, phosphorus, bicarb, chloride, carbon dioxide, all of these things affect the body. And when there is an abundance or an imbalance, right? Too much or too little, hypo or hyper, that's problematic, right? So very important to know. This slide lists the name of the various electrolyte imbalances that we will be covering in detail on the coming up slides. All right, first electrolyte, sodium. We know that a normal sodium level in the body is 135 to 145 milliequivalents per liter. Sodium is abbreviated as big N, little a, with the plus sign, right? A low level of sodium is called hyponatremia, and an excess of serum sodium is called hypernatremia. Again, sodium is an extracellular solute, and its main action is to fluid volume regulation. Okay, its main action is to regulate fluid volume. It stimulates the conduction of nerve impulses, right? ADH and aldosterone help regulate the amount of sodium, right, or sodium levels. When we're talking to our patients, we want to let them know recommended daily intake of sodium is 1,500 milligrams per day. But again, most American diets at least get twice that much in their diet. Let's start with the sodium imbalance of hyponatremia, right? Too low. This can occur from a loss of sodium from our cells. This can be from vomiting, diarrhea, maybe the nurse gets a little too aggressive on GI suctioning, or the NG tube is, when it's on intermittent suction, it's too aggressive again, right? Kidney disease, it could be caused from kidney disease, maybe too much of a diuretic medication and it's pulling way too much sodium off. It could be due to, we have huge losses, right? Fluid losses when we have burns. It could definitely be that. And in some cases with excessive perspiration, right? So a ton of perspiration. This loss could also stem from an ADH hormonal imbalance from things like head injuries, right? Big head injuries, big. Maybe patients who have AIDS can have imbalances with their hormones, and it thus can cause electrolyte issues. And tumors, you're going to discuss tumors. I think it's in block 4 that affect ADH hormonal levels. This loss could also occur when you have a gain of too much water from sources like tube feedings that have too much water in them, or if a patient just drinks way too much water themselves, or nurses rehydrate patients but give too much IV hydration, maybe like D5W, that's dextrose and water. It could be from an excess of any of those things, right? What would you see in a patient who was in a state of hyponatremia? Sodium mainly affects neurological functioning. So when you're trying to remember which organ is affected the most by, which organ is affected the most by which electrolyte, think of putting a salt shaker in your head. It may sound funny, but it'll help you remember, right? In hyponatremia, your serum sodium level falls below 135. The specific gravity of the urine will also be low due to the low number of sodium solutes versus water in the urine. Your patient will most likely have a change in personality. They may become very lethargic, confused, and apprehensive. They may also experience nausea, maybe even vomiting, anorexia, definitely going to see muscle twitching, cramps. Eventually, if the imbalance is not addressed and reversed, it will result in the patient having seizures. They will be a huge fall risk. They're going to be less and less neurologically intact. Eventually, they're going to fall into a coma and then die. So it's important that we catch these changes and obviously reverse them. As a nurse, we're going to closely monitor our patient's neurological status. We're also going to look at the sodium levels. We're going to look at urine-specific gravity levels, input and output, all of those things, right? We're going to encourage foods high in sodium when they're hyponatremic. Most likely the patient will be on a fluid restriction diet. And our IV fluids that we're putting in the patient is going to have sodium in it for sure when they're hyponatremic. And we may also need to set up seizure precautions for this patient, right? Very, very important. Okay, hypernatremia, what's happening is we lose water from our cells and there's a higher concentration of sodium left in the cells. This happens when we lose water. This can occur from water losses, say through hyperventilation, right? Fever, diarrhea, profuse sweating. It also can occur if we don't ingest enough water. It can also occur when we consume too much sodium. This can be through IV solutions, tube feedings, too much table salt. It could be to chronic diseases like diabetes insipidus, which you're going to learn in Block 3. But you should know that diabetes insipidus can cause hypernatremia. Heat stroke could also lead to hypernatremia as well, right? Because we're losing a ton of water, right? In your patients with hypernatremia, they will be extremely thirsty, right? Because it will initiate that thirst mechanism. They will have very dry mucous membranes and their tongue may be red and swollen, right? Because the drier the membrane becomes, the more swollen it typically becomes. Serum sodium levels, again, will be above 145. And urine-specific gravity will be over 1.015. In severe cases, they will also exhibit some neurological signs and symptoms as well. These could include behavior changes, lethargy, decrease in LOC, and then eventually they could be having hallucinations. They too could go into seizures and eventually could cause them to deteriorate even worse. Once again, we are going to closely monitor the patient's neurological status, their sodium levels, specific gravity labs, input and output, and all of that, right? They should have a low sodium diet, most definitely, and we would encourage or push fluids big time, not only through IV, but by mouth as well. Okay. Potassium is going to be the next electrolyte we're going to talk about. It is a major cation of the intracellular fluid. It is recommended that people consume at least 4.7 grams of potassium per day. And I will say most Americans consume less than that in a day. If we have good kidney function, we usually don't need to worry about consuming too much potassium and retaining too much potassium, right? But with those with kidney function, it could be problematic, right? Potassium is a very important electrolyte for the correct electrical conduction of the heart, all right? It's main electrolyte of the electrical conduction of the heart. In the next couple of slides, we are going to talk about potassium imbalances. In hypokalemia, the patient loses potassium from their system. This could be from vomiting or, again, a nurse gastric suctioning too aggressively. It could be from diarrhea. It could be from the use of potassium wasting diuretics. It could be from some antibiotics. It could be from steroid administration. It could be from poor intake of potassium-rich foods. It could be from hyperaldosteronism. It could be from polyuria. Again, it could be from potassium wasting drugs. So again, we have furosemide or loop diuretics, and we have hydrochlorothiazide or thiazide diuretics. Both of those are potassium wasting diuretics. Potassium imbalances mainly affect cardiac functioning. So now I want you to picture a big K plus right over the heart. Okay, so just like, kind of like the picture there. Hypokalemia will usually produce cardiac dysrhythmias. It can also produce muscle weakness, leg cramps, fatigue, nausea, vomiting. So this is going to be any serum potassium level that's below 3.5. These patients will be on a telemetry unit where the heart rate and rhythms are continuously monitored. We will give ordered oral potassium as well as encourage foods high in potassium. If potassium is ordered IV, we will need to assure to administer it extremely slowly so as to not put our patient in danger of creating a cardiac arrhythmia, okay? And you never, ever, ever, ever push potassium via IV, ever, okay? You're going to run it over a really long period or significant longer period. Don't forget to teach these patients how to avoid this condition again through diets and supplement, okay? So we're going to do lots of education with our patients so they don't end up back in the hospital with hypokalemia, right? Okay, hyperkalemia. There is an excess of serum potassium. This can be caused by retention of potassium. Let's say maybe your patient has renal failure, right? So they're not getting rid of all their waste, so they're retaining too much potassium. It could be, an aldosterone problem, so hypoaldosteronism. It could be the use of potassium conserving diuretics like spironolactone. It also could be caused by too high of intake of potassium. And many times patients don't even realize that salt substitutes are made many times with potassium. So they're using, a salt substitute. That's usually the very first question I'll ask a patient, if, are they using a salt substitute? Because they're, again, many times made from potassium. It could also be too high of an infusion if we have, potassium running to reinfuse. Maybe they were initially hypokalemic and we got too aggressive with how much we infused over a long period, right? Or it could be due to potassium shifting out of the cells and into the plasma, like when there is cell destruction, when we have, for example, severe burns, right? We got tons of cell destruction. So of course the plasma is going to shift out of the cells and go into the plasma itself, which that's where the blood is being drawn, right? From the plasma. That's where the labs are being drawn. The electrolyte levels are coming from the plasma, right? Once again, when thinking of potassium imbalances like hyperkalemia, think cardiac, as well as deep muscle involvement. These patients are vulnerable for dysrhythmias. These patients will also most likely be on a telemetry unit to monitor their heart rate, rhythm, and functioning. They can also display GI hyperactivity, nausea, diarrhea, muscle weakness, and flaccid paralysis. The lab value will have a potassium level over 5 milliequivalents per liter. As a nurse, you will monitor these lab values. You're going to monitor the cardiac status, and you're going to instruct the patient to avoid foods that are high in potassium, right? And foods high in potassium, baked potatoes with the skin, bananas, avocados, a long list, right? Excuse me. Okay, next electrolyte is calcium. It is responsible for bone health as well as neuromuscular health and cardiac functioning, right? Mentioned that in class. We do have one, a main electrolyte of every organ, but multiple electrolytes are responsible for maintaining the health of and function of those organs, right? 99% of calcium is located in the bones and teeth. If we don't consume enough calcium, our body will leach it from our bones into our blood to compensate. Let me say that again. It's a very important concept. If people do not consume enough calcium, our body or their body will leach it from our bones and pull it into the blood to compensate. This could lead to osteoporosis, right? And osteoporosis is a concept that's important for Block 1 that you need to know. Most Americans do not consume enough calcium daily from their diet, okay? It's a problem. And again, the normal serum calcium levels should be anywhere from about 8.2 to about 10.2, okay? When thinking of calcium imbalances, I want you to think about bones, nerves, and muscle involvement. Let's go over the risk factors for low calcium or hypocalcemia. This can occur as a result of removal of the parathyroid gland. And also, it could be other conditions that are listed on this slide. Hypomagnesemia, right? There's a correlation between calcium and magnesium, and if you have low mag levels, then you're probably going to have low calcium levels, right? It could be due to impaired vitamin D conversion, right? So patients who have, poor vitamin D conversion is definitely going to probably have hypocalcemia as well, right? We discussed that in class, the importance of vitamin D with calcium. Your parathyroid, if you have problems with your parathyroid, hypoparathyroidism, and ironically, hyperparathyroidism. You'll see that with some of the electrolytes like potassium, right? When you're low potassium, you get dysrhythmias, and when you're high potassium, you get dysrhythmias as well. They're different dysrhythmias. You don't need to memorize that for Block 1. You'll have to know it for Block 2, but they're still dysrhythmias. Same thing when you have hypoparathyroidism or hyperparathyroidism. It can lead to hypocalcemia, okay? For clinical manifestations, think neuromuscular. This usually includes numbness, tingling, tetany, muscle cramps, severe diarrhea. This condition can also have some cardiac involvement. It has unique manifestations in if you do Trousseau's and Chavok sign, you will be able to tell when a patient has hypocalcemia. So again, Chavok, that's how I say it. Chavoshek, I think is how some people say it. So when a nurse will do, an assessment for a hypocalcemia or hypocalcemic patient, they will tap the nerve that is over the cheek bone there, right? And if it twitches or causes that little facial jerk, then you know that's a positive Chavok sign, right? Trousseau is when we literally will pump up a blood pressure cuff above the patient's systolic blood pressure for 3 to 5 minutes, and then the patient will literally have a positive muscle spasm, right? So they get this adduction of the thumb, flexation of their joints, they get their hand turns in toward their body, and the flexion of that wrist occurs, okay? We call that a positive Trousseau sign. So we're going to be testing them for both Chavosek and Trousseau sign. That's so hilarious. We're going to look for the muscle spasms and contractions and all of that, right? Or that exaggeration of the blinking response. Again, their calcium levels will be below 8.2. And now you're probably starting to say, hey, wait a minute, some of these signs and symptoms overlap. How will I know what is really happening with my patient? And what I'm going to say is through very thorough assessments, data gathering, you're going to look at your labs, and all of this together is going to point you in the right direction. Now, that is exactly how you're going to learn this information and how you should study it as well, okay? As the totality of signs and symptoms that go together, because we've discussed this in class. How are we going to present these different electrolyte imbalances to you? And it's going to be in a patient example, right? So we might give you lab values. We may give you we'll definitely give you signs and symptoms, like we'll give you muscle cramps with tetany, positive trousseaus and Chevaux-Oxide, maybe some neurological mental changes, those kinds of things. And then we'll give you an option to pick hypo or hypercalcemia along with another electrolyte imbalance, right? And then you would be able to pick that, okay? In hypercalcemia, the risk factors are listed on this side. Again, we have patients who are prolonged immobilization is what's going to happen if they're kept in bed too long or they don't get up and move around. Their body again is going to break down bone and it's going to leach into the blood as a result, and it's going to cause hypercalcemic blood values and very weak bones, okay? Because if the calcium's in the blood, it's not in the bone where it should be, right? Again, if we have a parathyroid problem, so overactive parathyroid problem results in hypercalcemia. Malignancy of the bone would also cause calcium to leach, be broken down, and it would seep into the blood, resulting in hypercalcemia again. Thiazide diuretics cause hypercalcemia. And excessive calcium supplements or vitamin D would result in excessive large amounts of hypercalcemia. Clinical manifestations in hypercalcemia patients is going to be lethargy, weakness, really neurotic behavior, could be nausea, vomiting, maybe constipation, polyuria, and even kidney stones, and if not reversed, eventually cardiac arrest, potentially death, okay? We're looking at calcium levels well over 10.2 or above 10.2, and we need to make sure we get the patient up and moving, right? We need to get the patient up and moving because we don't need more bone loss and thus more calcium in our blood, right? We're going to be pushing fluids. We're definitely going to be not letting the patient eat any high amounts of calcium, any foods with calcium in it, or minimal, I should say. Limit foods with high amounts of calcium. That's a better way to say it. We would also encourage high fiber foods, and these patients are confused and neurotic. So they're going to be huge fall risks. So we're going to have to protect them, right? Okay, so next electrolyte, magnesium. Magnesium is a vital mineral. It is required to have over 300 biochemical reactions in our body. Okay, let me say that again. People don't realize how important magnesium is. It is required for over 300 biochemical reactions that are occurring in the body all the time, okay? Like calcium, only 1% of magnesium is in our blood. As you have learned in your nutrition chapter, magnesium assists the thyroid hormone. It also helps maintain our BMR. It activates enzymes for metabolism of carbs as well as metabolism of proteins. It assists nerves in muscle function, including the cardiac muscle, by the way. That's why I told you guys mag is important for cardiac function as well. Now, low levels of magnesium are rare, except in alcoholics, okay? It is very common in alcoholics. Chloride is found in the extracellular fluid and is usually bound with other ions like sodium and potassium. And it helps with acid-base balance, of course, right? That's how important magnesium is. In hypomagnesemia, the common causes are listed on this slide. Again, the number one cause, chronic alcoholism. Now, there are some other things like malabsorption. We talked about gastric bypass last week, and we know that they have absorption problems, right? Because that's how they lose the weight, right? By rerouting the stomach, and therefore absorption, to not allow the absorption of calories, but as a result that impacts the electrolytes as well, right? So we're going to look at all lower electrolytes with the gastric bypass surgeries and things like that. So it could be malabsorption. It could be because they're on a thiazide diuretic and there's too much wasting of the magnesium, right? Certain antibiotics also cause excuse me, low mag levels, and it could be increase in vitamin D. Diarrhea is also a cause, or prolonged gastric suctioning. So we talked about it again when somebody is on GI suctioning, intermittent, or we could be too aggressive with that, right? Clinical manifestations, again, of hypomagnesemia patients includes neuromuscular irritability. It includes neurological LOC changes, right? So they'll be disoriented. They could have severe mood changes and shifts. They could have dysrhythmias, which we've mentioned already, right? Remember, with certain meds, it can increase, the sensitivity to them. For example, digitalis, right? So you got to be very, very careful. Again, their magnesium levels will be below 1.8. It also affects, again, the heart, right? Dysrhythmias. And the increased sensitivity to digitalis medication. So one of the first things I do when I get my labs back, and if I see somebody, it's confirmed, I had it, they do have hypomag levels, is check immediately to see if they are on digitalis. Because if they are, then I know that's going to affect that, and I need to connect with the physician to have a conversation about how we want to adjust the dosage of digitalis, okay? Again, we're going to monitor the patient's I's and O's, provide them foods high in magnesium. We are going to avoid alcohol, monitor the patient's pulse rate. Again, if on dig, we're going to enact seizure precautions as necessary. All right. Okay, next is too much magnesium. And again, common causes of hypermagnesemia is renal failure, keeping too much electrolytes and waste in the body. Adrenal insufficiency, maybe we replace the mag levels and got too aggressive and we have excess replacement. Or it could be with hemodialysis with hard water, too much mag. I think, necrosis tissue can also cause it, adrenal insufficiency, and lithium intoxication. So that's going to be a big one. And you're going to learn more about lithium next block, right? When you take psych, but it can cause hypermag levels in the body. Clinical manifestations of too high of magnesium include flushed, warm skin, hypotension. You're going to end up with cardiac abnormalities. Your patient's respirations are going to be depressed, and they could be drowsy. Their mag levels, of course, will be above 2.6. We're going to monitor the patient's vital signs. Should have started with airway. We're going to monitor our patient's airway, number one, their vital signs, number two, and particularly paying close to their respirations, right, as part of their vital signs, because we know it's going to suppress the body's natural respiratory effort, right, which isn't good. We are going to monitor also reflexes. We are going to avoid magnesium-based foods and also medications that contain magnesium. Okay, so again, magnesium-based foods. You just had nutrition, so you should be able to get any questions about this on the test accurately, right? So whole grains, leafy veggies, broccoli, squash, those kinds of things, right? Nuts have a lot of phosphorus in them. Again, most of the phosphorus in your body is bound with oxygen, becoming phosphate. Phosphate binds with calcium in your teeth and bones, right? So there's a correlation between phosphate and calcium, right? They have an inverse relationship. As the blood level of one of them goes up, the other one goes down. That's important to know, right? Calcium and phosphate have an inverse relationship. As the blood level of one goes up, the other goes down. Again, normal levels for phosphorus should be 2.7 to 4.5. In hypophosphatemia, the common causes are listed on this slide. Again, it could be due to alcohol withdrawal. It could be a diabetic that has gone into diabetic ketoacidosis or DKA. It could be someone who is in respiratory acidosis, like your COPD patients. It could be due to parenteral nutrition or refeeding a patient who is has been starving for a long time. It could be due to us giving glucose, maybe IV fluids that has glucose in them. It could be any of those reasons, right? Signs and symptoms would include anemia and bruising. Eventually could lead to seizures, coma, and death. Patient's going to be constipated. They may have muscle weakness. Obviously, hypoactive bowel sounds. Remember, we talked that it suppresses respiratory effort, so the patient could end up with acute respiratory failure. They could have paresthesia, joint stiffness, cardiomyopathy. Again, impaired oxygenation to the tissues due to that respiratory depression. Remember, the phosphate level is going to be below 2.7. Again, we need to monitor the calcium levels as phosphate is being replaced. And start any parenteral nutrition very slowly so that we do not drop the phosphate levels lower, okay? Got to monitor our patient for diarrhea as well. Okay, hyperphosphatemia. Again, renal failure because we're keeping too many waste and electrolytes in our body, right? It could be too from chemotherapy. It could also be from patients consuming a large amount of milk and large amounts of vitamin D. It could be an excessive use of phosphate-based laxatives. That's a big one, right? Especially with the elderly. Some elderly patients are consumed with their bowels, right? And if I get a hyperphosphorus patient, I will have a discussion with them if they're elderly and say, how are your bowel function and things like that, because it's able to open the door to have conversations that, I have to have an enema, twice or 3 times a week, which we know causes a dependence on them, right? If we continue to do that, yeah. Clinical manifestations include tetany symptoms in short-term excess levels. And if levels are high enough for long periods of time, calcification in the soft tissue can occur. So we're going to get, again, tetany, tingling of the extremities, maybe the mouth, maybe muscle spasms. Again, long-term, though, would be calcification in the soft tissues, calcification in your kidneys, in your joints, in your arteries, in your skins, in your eyes, the cornea, right? Again, phosphate level will be above 4.5 if they're hyperphosphatemic. Again, we're going to monitor for tetany. We're going to administer aluminum hydroxide with meals. This will help bind to the phosphate. that's in the body, and that's in the bloodstream, and therefore will help remove it, right? We're going to monitor our phosphorus levels. And we're going to make sure that we're not using any phosphate containing laxatives if we need to use a laxative. And we're going to do education to our patient if that's what brought them in, also about proper bowel habits, right? Okay, so as a nurse, we are going to conduct a full health history, a full head to toe assessment. We're going to perform clinical measurements. We're going to review laboratory data. The nursing history should include age, acute illness, chronic illnesses, pre-existing conditions. Has the patient had any burns, surgery, any respiratory disorders? We're also going to assess for kidney failure, cardiac conditions. Does the patient have diabetes? All of these factors are going to have a piece of the fluid balance, right? Acute conditions also, we're going to monitor for, has the patient had any vomiting or diarrhea, NG suction, burns, all of that's going to play a factor. We're also going to look at medications like diuretics. Those need to be assessed. Treatments even, right? Have they been to dialysis or chemotherapy? All of those play a factor. Their age, access to food, and clean water. That may also be a factor. We're going to do a focused physical assessment as well, assessing the skin, mucous membranes, cardiovascular function, neurological system, looking for any signs and symptoms of fluid or electrolyte or acid-base imbalances. We'll also be checking vital signs for an elevated temp. We're going to check the apical and radial pulses for tachycardia, for bradycardia, for dysrhythmias, for pulse strength. We're going to look at the respiratory rate and blood pressure and evaluating for abnormalities that may indicate imbalances. We will want to get a daily weight on our patient, make sure it is obtained at the same time of the day with the same clothes on, with the same scale, as all of these things can be variables. Excuse me. We're going to complete a full blood count with an RBC and red blood cells. An increase in red blood cells may signal dehydration, and a decrease could indicate overhydration. An increase in serum osmolarity will indicate dehydration, and a decrease in osmolarity will indicate overhydration. So we're going to look at serum osmolality as well. We're going to look at blood and creatinine levels and provide information related to fluid status and renal function, right? When we look at blood and creatinine, it can tell us a lot about how the kidneys are doing and whether or not it's able to get rid of waste. We're going to look at normal urine specific gravity measures, the amount of solutes to solvents. Normal range is approximately 1.001 to 1.030. An increase will indicate dehydration, and a decrease will indicate overhydration. Urine pH is usually acidic with a normal range from about 4.6 to 8.2, averaging at about 6. We will not be reviewing arterial blood gases, which is your acid-base imbalances, because you're going to have that in block 2. Okay. Now we get to go to diagnosing. Any of these nursing diagnoses could be appropriate for a person with fluid imbalances. Deficient fluid volume would be associated with dehydration or possibly isotonic fluid loss. Excess fluid volume is associated with an increase in isotonic fluid retention. Risk 4 is when you have a potential for these fluid losses or gains. Risk for deficient fluid is associated with risk for vasculature loss or cellular loss or even intracellular dehydration. Take a moment and look up these in your Lippincott Advisor or your book if you're unfamiliar with them, okay? Our goals or outcomes should be associated with getting the patient back to fluid balance by using measurable findings to support the resolution of these problems. There are a few possible outcomes listed on this slide. Please pause the video and take a moment and review them, okay? One of our main jobs as nurses is to teach our patients about their condition and ways to prevent it from happening to them again. To promote fluid and electrolyte balance, we need to encourage patients to limit their sodium intake and increase their dietary potassium and calcium. Patients may need to take potassium or calcium supplements. Potassium supplements are usually very large pills and may be hard to swallow, especially with our elderly patients. We may also need to administer diuretics. We will need to carefully monitor the patient's intake and output, as well as their serum electrolyte levels, to ensure medications are having the desired effect without depleting the patient's potassium. The upcoming slides will go over facilitating or limiting fluid intake. We will also need to address and be supportive of patients' anxieties regarding any changes in their condition, and when discussing, the treatment plan and the proposed outcomes, okay? On this slide, these are the measures we can teach our patients to maintain fluid and electrolyte balance. 8 to 10 glasses of water per day is the best fluids to ingest. Again, we're going to avoid foods that are excessively salty, too much sugar, or tons of caffeine. So we're going to encourage eating a well-balanced diet, right? We talked about nutrition in the past, so we're not going to cover it again, but you do need to have that information at all times, right? Going to limit our alcohol intake, increase our fluids before, during, and after strenuous exercise. We're going to replace any lost electrolytes, maintain a normal, healthy body weight. We're going to monitor and manage any side effects from medications. We're going to recognize risk factors, and we're going to make sure that the patients are seeking out professional help when they start to have any signs and symptoms of imbalances. Sometimes we need to encourage enhanced fluid intake, or what we call push fluids, right? And this requires that a nurse explain to the patient the reason why we're going to focus on increasing their fluid intake. The patients need to know that the intake goal, exactly what it is, right? So they can work towards achieving that goal, and also help keep track of their fluid intake. We need to create a 24-hour intake plan, allowing for more fluids to be taken in during waking hours and with meals, then obviously later in the evening, because we don't want to impede or affect someone's sleep. Find out what the patient likes to drink and provide those. Just make sure they don't contain too much caffeine, as that is a diuretic, okay? And if they select foods that become liquid at room temperature, those items can also be counted, so encourage those as well. And if they like to drink through a straw, make sure they have plenty of straws available. If a drink is meant to be hot, serve it hot. And also find out if they like ice or no ice in their drinks, right? Because that can make a big difference in wanting them, for patients wanting to drink more. Also, again, make sure that any fluids that you are encouraging complement the patient's cultural preferences, religious preferences, and beliefs, right? All right. Sometimes we need to restrict fluid intake. This requires that the nurse explain to the patient the reasons why they're on fluid restriction. Once again, we'll need to create a 24-hour intake with the patient, allowing for most of the allotted fluid ingestion during the day when they're awake, and with meals, rather than equally throughout the 24-hour period. Do not leave pitchers of water within the patient's reach or even in the room, as they may drink their full 12-hour allotment in one sitting. Instead, provide only smaller cups of fluid. Ice is great because a cup of ice is only half the volume of a cup of water, and it satisfies a dry mouth. Okay, so use ice. Avoid foods that would make the patient thirsty, right? So really salty foods, sugary foods too, right? And get them involved in the care so they don't feel so powerless. And they can feel powerless when they're on fluid restriction. It can be very difficult for them. Lastly, we need to evaluate our patient for the effectiveness of our interventions and teachings, right? Evaluation should be ongoing so we can change the treatment plan in a timely manner as indicated. The items you will be evaluating are listed on this slide. Take a moment, pause the video, and review them. Also, to see the evaluative statements in a possible document, so please go to your textbook again and look through the nursing care plan and review the evaluative statements, okay, because they're important, right? Has their drinking, eating patterns or hydration status changed? Input and output measures, any normal fluid loss, daily weights, are there signs and symptoms still occurring? Can the patient describe ways to avoid fluid and electrolyte imbalances in the future? All of these things are extremely important. Okay, this is the end of this chapter.